Thanks to everyone who's joined us this evening. It's great to have you with us for what is the second session in our Victorian Rural Health Conference 2021 virtual speaker series. And the topic for this evening is rural maternity services. So we have a really great panel who I'm going to introduce in a moment. My name's Sky. I'm the current Vice President of the Rural Doctors Association of Victoria. And before I start, I'd just like to make an acknowledgement of country. So we would like to acknowledge the traditional custodians of the lands from which we're all on, wherever you may be in Australia at the moment, in Victoria at the moment. And we'd like to pay our respects to elders past, present and emerging. And we'd also actually like to extend that respect to any other First Nations people who might be joining us for this webinar here tonight. The other thing we'd like to acknowledge is that First Nations women have been birthing on country for thousands of years, and we just think that that's a really important point to start on. So to introduce our very esteemed panel, first up we have Dr. Louise Manning, who is a rural generalist obstetrics registrar in Bendigo in Castlemaine, and she's the chair of the Rural Doctors Association of Victoria Rural Maternity Services Working Group. So thank you, Louise. We've got Dr. Nisha Khot, who's a consultant specialist obstetrician gynecologist. She's a Rural Doctors Association of Victoria board member, and she has worked at Bacchus Marsh, and she brings that experience with tonight with her. And we've also got Dr. John Hall, who's a rural generalist obstetrician, currently practicing. He's president of the Rural Doctors Association of Australia. And as you will soon learn, he is very passionate about rural maternity services. So the purpose of tonight is a few things. First is we're going to think about the challenges and the future sustainability of rural maternity services. We want to think about the safety of rural maternity services. That's a hot topic that comes up all of the time. We want to really analyse what the current situation in Victorian rural maternity services is in the current day. And for our attendees, you will actually have the opportunity to ask some questions and to raise your own issues directed towards the panel. So please use the Q&A icon to submit your questions. So what we'll do to kick off is we'll give each of our panelists just 5 minutes to tell you a little bit more about themselves and their area of work, their passion, their advocacy in rural maternity services, and then we'll open it up for panel discussion. So why don't we hand it over first to Dr. Nisha Khot?
Sure, why not? As Sky said, I'm an obstetrician based in Melbourne, basically. And when I started at Bacchus Marsh, I went there with the assumption that obstetrics is obstetrics, whether you do it in the city or you do it in a small place, it doesn't matter. Babies are born the same way. You still do cesareans the same way. It was, to be fair, not quite true, as I discovered when I got there, that rural maternity services come with their own set of challenges, and those challenges are less to do with how to do a cesarean and more to do with where you're doing that cesarean and who you're doing that cesarean on. So it was a steep learning curve, and I must say that I've benefited hugely from working at Bacchus Marsh and getting to know how rural services work. From there, because of my interest in education and governance, I've gone on to be part of the Maternity Simulation Education Program, which runs in Victoria and run through the Royal Women's Hospital and provides simulation-based education around rural and regional maternity units, mostly rural, small rural maternity units. It's a program that, because it's external, can sometimes give rural maternity units that external input of what's happening in different places and help them maybe update their policies, maybe think along the lines of what they could be doing better. So that's where I come from. I am passionate about rural maternity services staying open from a very selfish point of view, because I also work in the city at two of the busiest maternity units in Australia, and I don't want them getting busier. So I would much rather have rural women have their babies locally in their local hospitals so that I can sleep at night.
Thank you, Nisha. So we'll hand over now to Louise.
Thanks, Sky, and thanks, Nisha. Can you hear me through the little microphone Awesome. I just had a bit of background noise. As Guy said, I'm Louise. I'm a rural generalist trainee with both ACRRRM and FRACGP. Don't know why I'm one of those crazy few that wants to become a dual fellow, but advocacy is something that I've been involved with for a number of years since medical school now, particularly within the rural health sphere. And for me, I'm a bit political, so for me it makes sense, but I would not recommend it to anybody else in the audience. Too many exams. So I undertook my obstetrics year or advanced DRANZCOG training in 2019 in Bendigo, which is a great unit where there's a decent number of births to get a good amount of experience. And then over the last 18 months or so, I've been doing a little bit of kind of on the side GP obstetrics and shared care kind of model across Castlemaine, Maryborough, and then still doing some consolidation of skills in Bendigo. It's been quite different, obviously going out to these smaller level 2 services compared to a big level 5 like Bendigo, just in terms of the resources that have been available to me and in terms of the staffing pressures, and I'm sure that will come up later in our discussion, but staffing is obviously a really major consideration when it comes to rural services and keeping them functional and viable. So I can talk a little bit to that. And yeah, I'm currently pregnant myself, so something to think about in the not too distant weeks coming forward, and how my growing family can impact on my ability to provide obstetric services in small rural communities moving forward.
Absolutely. Thanks, Louise. And John, last but certainly not least, do you want to take the floor?
Yeah, thank you so much, Sky. Look, it's great to be part of tonight, and thank you everybody for joining as well. Look, rural maternity services have been a passion of mine since my involvement in the rural doctors movement. I was RDA Q president in 2007, and during my early sort of registrar and student days, it became very apparent to me when I was scoping out jobs and talking to different rural and remote sites where I might want to work, that many of the doctors that I spoke to said, have you got obstetrics? Can you do obstetrics? And it became apparent to me that it was one of the key skills that many rural sites were looking for. And I think it then sort of fed on to sort of part of my career path in doing obstetrics. I wasn't particularly interested in obstetrics as a career, but I went down that path because I could see that there was a significant need. And then when I got into it, I absolutely loved it. In fact, I nearly became an obstetrician because I enjoyed my DRANZCOG year in Mackay so much. But really, what has driven me in the rural political space is seeing how important rural maternity services are for the general viability of a rural health service. And this is a mantra that you've heard me say before, and you've probably heard in many other forums, but when you lose maternity, you lose operating theatres, you lose skilled nurses, you lose doctors with anaesthetics. Basically, a lot of these hospitals become downgraded, and the level of skill and the level of access to service to the community goes down. And that has a big knock-on effect to community development as well, when you have the loss of a number of health professionals and a significant downgrading of the service. Remembering that rural hospitals are some of the biggest employers in country towns, and they are key to community development, and people want to live in an area where they know they can get a full range of health services, particularly being able to birth locally, and for the elderly, knowing that they've got access to acute and inpatient services as well. So I guess that's sort of my passion and where it's come from, but I'm really excited to be involved tonight, and certainly happy to be around to answer any questions about numbers and statistics and safety. Safety is one of my biggest bugbears, and I would say to you, it's less safe to remove services than it is to say it's unsafe to do this practice rurally.
Thank you, John. So what we're going to do now that you've heard a little bit about who each of these fabulous people are, we're going to open the floor up for questions. I've got some questions that I can start us off with, but if you've got some questions, can you put them in the Q&A function down in the bottom of the screen, and we'll try and answer as many of your questions as possible. Also accepting interesting, thought-provoking comments. So if you're the sort of conference attendee that likes to make a bit more of a comment than a question, that's fine by us. So maybe to start with, John, we'll pick up on the theme that you just raised around safety. You know, we see it in the media all of the time. There are concerns about the safety of rural maternity services, particularly in Victoria recently. There's been a lot of press around it. The concerns being that we are not providing safe care for women in rural Victoria. What are your thoughts? And John, do you want to start?
Yeah, look, absolutely. It's completely disingenuous for governments to say that rural maternity services are unsafe. They have a point to some extent if it's not a fully functioning maternity unit. But I think the inference often goes beyond that. The inference often goes beyond sort of saying a dysfunctional unit is unsafe to saying that the provision of high-level specialty care by non-obstetricians, by non-GP specialists in rural is less safe. Now we have long-term data. We have about 30 years of data from numerous published and unpublished sources that shows that the perinatal mortality rates in functional rural maternity units are on average, about 2 points lower than the national average, which is what you would expect. It's what you would expect because we risk stratify. So in the Atherton data that was published in the Australian Journal of Rural Health, their perinatal mortality rate was 5.3 in 1,000. We know that the national average at the time was 9.2. So that's a significant safety improvement. And I actually think often, I've had questions, or I've been challenged in conferences when I presented this data and other data that we have looking at long-term analysis of perinatal data collection from Queensland in particular. It backs up this data that there is improved perinatal mortality rates, lower Caesar rates, lower induction rates. Basically across all of the key indicators in maternity care, we have lower rates of poorer outcomes. So it's really disingenuous when governments say it's not safe. And I think the other big safety sort of data, I guess, that I like to point out is that we've shown that in these data, the perinatal mortality rate goes up significantly in areas where you remove access to services. So I think that's a really key point. And we've all experienced, those of us that work in rural maternity, precipitous birth, unplanned preterm birth with unwell neonates with significant respiratory distress, where we know if there wasn't a maternity service locally that those babies would have had poorer outcomes, and a huge proportion of the increase in perinatal mortality in areas where there aren't maternity services are from the disadvantaged, often Indigenous, underprivileged groups where they've had limited antenatal care and they've had they've had poor access to care. So these are the groups who are seeing worse perinatal outcomes. So at the end of the day, to say that it's unsafe to deliver is disingenuous when we know that there's data that shows that it's less safe for our communities and when we remove services.
Thanks, John. Nisha or Louise, do you want to comment on that question?
Yeah, I will comment. I suppose for Victoria, the reason why rural maternity services became such a big issue was Bacchus Marsh and what happened there. But if people have read the Targeting Zero report, which I think every Victorian should have read, every Victorian that works in maternity services should have read, the issues were systemic. They were not specific to rural maternity units. And that is something that we need to take away from the whole experience, that actually there are systemic issues within the whole of maternity service provision for the state. And if we work collaboratively and we do it well, we won't have those same outcomes. We will have better outcomes because we're working together. The second thing is having a safety...
Sorry to interrupt you. Just for anyone in the audience who may not be so familiar with what the issues in Bacchus Marsh were, and I know that might be a bit of a loaded question, but is there a sort of a quick, just, one sentence synopsis for those people so that they can...
Absolutely.
Yep.
Absolutely. There is a one sentence synopsis, which is that it was a small rural maternity unit which wasn't equipped to deal with the sharp increase in births because it was a growth corridor. And with those increase in births, what should have accompanied it is a safety mechanism, increase in staffing, increase in equipment, all of those things, and they didn't happen. And that is always a recipe for disaster, no matter which specialty you're in, no matter what your location is, whether it's rural or whether it's metropolitan. If your numbers go up and your services don't keep up with it, you're not going to have good outcomes. And so that is basically the crux of the matter. And so that is not something that is limited to rural maternity services. It becomes more obvious in rural maternity services because there's usually 5 midwives and 2 doctors. And so when you have a sharp increase in numbers, then it is that same small group of people who are coping with those increases. The second thing is actually having a safe practice framework, if you like. So rural maternity services are not the be all and end all and can't provide maternity services for everyone. We need to identify who we can provide those services for and provide them safely for those women. And the women that are outside of that practice framework need to go to a different center. That doesn't mean we can't look after them. We can do it collaboratively. They can have some of their care locally, some of their care regionally or at metropolitan centers. But the key to it is working together as a team, not as a team just of the team that works in a particular hospital, but a maternity team across the state. We are all here to provide maternity services to the women of Victoria, whether we do it at the Royal Women's Hospital, whether we do it at Bacchus Marsh Hospital or at Castlemaine. We're all here for the same reason.
Mm-hmm. Absolutely. Thank you, Nisha. Louise, was there anything you wanted to mention on that point? I can see we've got a lot of questions coming through, but I wanted to throw it over to you if you've got anything to add.
I'll just second that collaborative care is the most important approach that we need when it comes to maternity services, not just through the doctors providing actual birthing or the midwives, but also, as John slightly mentioned earlier, we need to make sure that we've got anaesthetic colleagues so that we can offer emergency services for Caesars if we need to. We need to have like the whole gamut of hospital staff available and ready to support women, because we'd much rather that they come in and deliver precipitously with us than have a baby on the side of the road. So we really need to rethink how maternity services are run across Victoria. We need to remodel how training for both GP obstetricians and FRANZCOG's trainees is running, and there needs to be a more equitable distribution of these trainees across the board to help to support these smaller services to continue running, and to also upskill the current clinicians that are working in these environments to make sure that they stay safe and up to date.
Thank you, Louise.
And just following on from Louise, building better roads is not the answer to providing good maternity services.
Thank you, Nisha. Very topical. Thank you to everyone that's putting the questions in the chat. We're going to start working through them, and we'll try and get through as many as possible. Fiona has kindly asked a question in the chat which says, what potential do you think midwifery continuity models of care can play in sustaining rural maternity services? Who from the panel would like to field that one first? John.
Yeah, look, I think this issue is really important. As Louise touched on, it takes a team to deliver maternity care, and we need not only midwives, theatre nurses, but also our GP anaesthetic and our GP obs colleagues. I think in a lot of rural maternity units historically, there's been a very medical sort of top-down model that relied on the doctors coming in all the time and relied less on our midwives to work independently. And to be honest, and I've reviewed a number of maternity units sort of on panels and things where in places where there's been poor outcomes and that type of thing. And to be honest, I think it's not only the doctors that have driven medical models in the past, it's actually our midwife colleagues as well who have grown up and taught and learnt their trade in medical models. So, and often they feel uncomfortable about becoming more independent without the appropriate training and exposure to being independent. So I think that's something that we need to remember. It's not always the big bad doctors in the background sort of wanting to drive a medical model. I think that the system is set up around a very hierarchical medical model, whether we like it or not. And if we want to transition to more midwifery led care, which I think is, that term I'm not overly comfortable with, but that term I think that the concept that we all know as midwifery led care, I think is important and we strongly support. I like to call it collaborative care, because the models where I see it working the best is where we work really collaboratively and closely together. And for instance, you have midwives working to the top of their license. You have them doing things like suturing, perineal repairs and lacerations. You have them providing more of that care without having to call on the doctor, which protects our rural doctors, keeps them in bed and keeps them fresh and ready in case they have to come in for a Caesar or help to manage a complex, unwell neonate, remembering that we're the neonatologists as well in rural. So I think it plays a really important role, but I would go on to say that we need a rural generalist pathway for midwives. We need more incentives for midwives as well as doctors. And I know now there's a number of examples in rural Australia where we've got enough doctors, but some units are closed because we actually don't have the theatre nurses or the midwives able to provide the care. And just so everybody realises, the caseload model of pure midwifery-led care, a lot of midwives don't like doing that because it means they're on call 24/7, 365 for their patients. So I think remembering and consulting and bringing our rural midwife colleagues along for the journey is really important. Many of the midwives that drive this conversation are metropolitan midwives that work in really big teams. And I think it's really important that we, as well as they, listen to their rural colleagues and that we make sure we build models that are fit for purpose in rural.
Thank you, John. Nisha or Louise, would you like to add anything to that? No, feeling satisfied?
I think the continuity of care model is a really great, model of care. But like John said, we need to have a mixture because it won't be what all midwives want to do. And so we need to have a mixture of the sort of midwives who would want to do work in that model, but also have the midwives who feel more comfortable working outside of that model, because it's not for everyone. Absolutely, we should provide all possible models of care to women in rural Australia. There's no reason why rural women should miss out.
Thank you, Nisha.
I'm just going to play devil's advocate for 2 seconds.
Go.
So I think in smaller units where there's not high birth numbers, there needs to be the capacities that both our midwifery and our GP Obs colleagues have hands-on time so that they don't de-skill. I know that there's a number of funding models that are currently available within the state that can help upskill midwives and that can help upskill GPOs. And it's just a matter of, I guess, finding a balance so that everybody feels like a collaborative part of the team and that everybody feels like they've got the skills to be able to do their job. The danger is where you get one part of the team doing perhaps more of the roles of the other part of the team, and that's when you can see significant de-skilling, and we've seen that recently in Castlemaine, and thankfully we've got a new model that's in its infancy since March, so we're hoping that it'll work, and that is based on midwifery caseload with for low risk women, and then for amber risk women have more GPO involvement as well, and then we've got a relatively close by regional centre that we can send our high risk women to. We're very lucky in that regard. So yes, I think it can be a really good model in the right circumstances, but we just need to make sure that everybody's able to maintain their skill set, because if people aren't using skills, that's when potentially these safety issues can arise, and we just need to make sure that everybody's where they need to be to provide a safe service for the regional women in their area.
Thank you, Louise. The next question I'm actually going to be throwing straight back to you, Louise, so it's going to be back-to-back answering for you. But anonymous attendee, whoever you are out there, has asked, are there any challenges for trainees in fulfilling the requirements of GP obstetrics training in a rural area? E.g., do trainees ever find it difficult to gain access to enough births, complicated births, etc.?
Thank you, anonymous person in the audience. That's a really important question, and something that I find my daily life has been for the last 18 months or so since I moved from a level 5 service predominantly where there were heaps of births and you were able to do lots of hands-on skills and you were seeing a lot of high risk women, to then being predominantly in a service that had a temporary pause and has been closed for the last 12 months, and another service where we only see about 50 to 60 births a year. So I guess it really depends on where you're planning on training or basing yourself. If you're lucky enough to be in a large centre like Ararat or Echuca, you're seeing quite a lot of births and you'll get a lot of extra hands-on experience. If you're in a smaller centre like I am, I have had it quite challenging, and without doing ongoing consolidation at that larger level 5 service, I wouldn't have as many births or experiences as I would want or need. I guess the main challenge is that the model that currently exists for the advanced DRANZCOG, let's use that as an example, is generally 12 months. The likelihood of actually completing all of your logbook requirements in that 12 months, I think, is very optimistic, and most people take longer, which means that all of the consolidation of skills funding often goes to these larger regional centres so that trainees can then be have some sort of ongoing employment in like a 0.1, 0.2 capacity to finish off their requirements. But it means that by the time they finally get to these smaller communities and they need the support of more serious and senior GP obstetricians in the area, that there's no funding available, which means that if you've got a supervisor, they have to kind of come in off their own bat, and you can't bill Medicare twice. And the incentives to provide good supervision aren't necessarily there, and you're often really relying on the goodwill of your mentors and supervisors in that environment. So I guess that's something that we as the RDAV Maternity Rural Working Group are kind of working towards, is thinking about how we can mix things up to change the structure for training and ensure that additional funding can be available for these trainees, so that when they do go out into these smaller services for the first time and they have to be on their own and they don't have a consultant obstetrician on call that can come in like this, that they feel comfortable and safe and that they can develop their skills in a supported environment.
Thank you, Louise. Yeah, John, take it away.
Look, I think this is a really, really important issue in the modern era because there are things that have changed about how we work that have affected things like throughput and what we get exposed to. So when I did my DRANZCOG, I did 120 Caesars in 1 year, and I majorly outstripped all my requirements of my logbook because I was working in a busy unit in Mackay in central Queensland where there was about 2,500 births a year and there were 3 PHOs on the on-call roster. So we did a 1 in 3. Now, I don't support that model of care, but obviously it leads to accelerated learning. In the modern era where we've got better work-life balance and fatigue management, which is also important, there is this issue of exposure, not only in training, but as we practice in practice in rural maternity units. And many of the rural maternity units that used to run on a 1 in 2 roster have now got 7 or 8 doctors providing on-call services to have a palatable work-life balance. This is going to be an ongoing challenge for GP proceduralists. And I think we need to come up with really good and structured, innovative models of how we get our numbers. And I think that needs to, I think part of the issue with exposure to training is not just, the work-life balance and fatigue management and more staff around. I think there are certainly some regional centres where GP obstetrician trainees don't get the preferential exposure compared to their other registrar counterparts as well. So I think we're fighting harder to get exposure to procedures, and that's something that we could work on a policy level and certainly more advocacy through the states to get our GPO trainees access to more procedures. And I've been a GPO supervisor quite a few times, and I've had to go into hospitals and talk to the head of departments and say, look, my registrar is not getting enough procedures, and it's because they weren't being given the same exposure to labour ward and theatre as their registrar colleagues. So there often is that advocacy that needs to happen. But when it comes to keeping our numbers up in practice, I think having really good structured upskilling where you do go to a larger unit for an extended period of time, two weeks or 4 weeks a year or whatever, is going to be really important. And I think there's a concept here that I've thought of and spoken to some of our overseas sort of aid agencies as well about the concept of us going overseas and actually going to places where there's real need and providing some services and getting sort of increased exposure there. So I think we need to be thinking about how we get increased numbers. But I would caution the concept of saying not getting enough numbers is unsafe. That's often a colloquial view. there's actually no evidence that supports that, that specific numbers, lower numbers lead to lower safety. I think it's related very much to the exposure that we get during training. And, you know, the reason why I'm cautioning that is not amongst ourselves, but there are credentialing agencies that are looking at magic numbers and saying, you know, if you don't do X number, then you won't be credentialable. And I think that's a really fraught path to go down because, you know, I know many occasional proceduralists who are very highly skilled and are able to maintain their skills even with lower numbers. Colleague of mine, Bruce Chater, worked in Theodore in central Queensland for about 30 years and still working there. They closed his maternity unit because they had low volume. They were birthing between 20 and 50 a year. He had 0 maternal deaths over that period of time and a very, very low perinatal mortality rate. So I think we need to sort of be cautious about talking about low numbers being linked to safety, but at the same time, understand that our colleagues in medical administration and our specialist colleagues will be looking at that. So we do need to continue to come up with strategies so that we can maintain our exposure going forward.
I guess clinician comfort is probably more where I'm getting at in terms of low numbers. If you are only just starting out and you've only just met the requirements for the logbook, and then DRANZCOG says, go forth, go do Caesars independently. If you haven't got 30 years worth of obstetric experience, to have that comfort that if you're only getting 15, 20 births a year, then because those skills are fresh, they degrade quickly, whereas obviously with long-term consolidation and use, you feel more comfortable.
Couldn't agree more.
Yeah. From a training perspective, low numbers is not a good thing. Ongoing, I 100% agree with you in terms of safety concerns. But yeah, as a trainee, numbers are really important.
Nisha, anything that you'd like to add around this particular topic?
All I will say is that flip it around from being just a GP to being actually just a specialist. I mean, John and Louise have got so many more skills than I have. All I can do is a cesarean or an instrumental delivery. That's about it.
I'm sure you're underselling yourself there, Nish, but we love the sentiment. We've got a few comments and questions coming through in the chat. So we've got Graham Slaney joining us. Thank you, Graham, who's provided a comment. Graham's the clinical lead for obstetrics for the Victorian Rural Generalist program, and he's just letting us all know that VRHC21 are doing a study on the training outcomes and retention of rural generalist obstetricians in Victoria, looking at 2016 to 2020. So hoping anyone who might come across this can support the review of the training when they're contacted. So thank you, Graham. We have a question from Sema, which I think is quite an interesting question. Obviously, Sema, the question, and I'll read it in a second, is quite specific to your circumstances, but I think it can be extrapolated out, and that might be the angle that the panel is able to answer it from. You've mentioned that you're a current GPO in Bairnsdale and actually are in urgent need for an advanced GPO in the practice in Bairnsdale. And if you don't recruit actually quite soon, you will potentially have pretty serious impacts on your service at your local hospital with around 350 to 400 births a year. And the question that Sema's asked is, you know, we're about to start advertising, you know, how can we increase our recruitment network? And I think that probably applies to a lot of services in Victoria. Who might have some advice around that? John's telling us to pray.
No, look, I'm happy to jump in. Look, this is difficult, and I think one of the problems is that when public health services say they're advertising to recruit, that often amounts to, you know, one ad in the MJA or, you know, a medical magazine, and I certainly feel that many of the state-based authorities don't put enough effort into recruiting. You know, when you look at recruitment agencies and sort of the high touch, very hands-on way that they go into the market and recruit, and, you know, they'll drill, you know, phone lists of hundreds of doctors, and they'll, you know, so there's a much more hands-on approach that often happens through recruitment agencies or locum agencies. For my day job, many of you may know I work for Ochre Health, and they've got a recruitment agency, Ochre Recruitment, and this is how I sort of know so much about this process. But I get involved as their medical advisor in terms of looking at CVs and how we tap into different markets, and they have a really large database, as do all of the other private recruiting agencies. But the point I'm trying to make is that I don't think state governments and health departments put the same level of effort in, and often they outsource this to private agencies. I'd like to see state health departments having a recruitment department, particularly for rural, where they employ professional recruiters and actually work on this sort of high touch, high level recruiting. And also I think you have to be innovative in the market, and we should be, we need to be going to market with attractive packages, premium packages. And this is where things like single employer are coming into play, where we can bundle up, what someone might earn in the GP practice to what they might earn in their state, from their state remuneration, and sort of actively go to market with some uplift so that it's more attractive. So I think we need to be really on the front foot with that. At the moment, I think the only people that are doing that particularly well are the private recruitment locum agencies. We might need to take a leaf out of their book when it comes to state-based recruiting.
Thank you, John. Any other comments from the panel? Yep, Nisha.
I will say a couple of things. First thing is that the offer of being able to work part-time, I think, makes a huge difference to any sort of, if I were looking at a job, I would see, can I do this part-time? Because that is something that is really important, especially to doctors who have other interests. And I don't want to pigeonhole it as a women's thing of, women having babies or whatever. As I said to other people, it's not just the woman having a baby. There are two people involved there, but it's just having other interests and being able to pursue those other interests. So advertising for part-time jobs, I think, is important to kind of put it out there. And the second thing is not so much recruitment, but actually when you do find someone, value them. Because people start off with lots of enthusiasm, get burnt, and never want to go back to rural practice again, which is a shame because they came in with enthusiasm. What have we done for them to lose that enthusiasm for that sort of work? So once you've recruited someone, as Shakespeare would say, bind them to thy soul with hoops of steel.
Thank you, Nisha.
Succession planning is a really big problem for most rural units in general. So even getting GPs out to general practice in smaller communities is a massive challenge these days. And we know that despite record numbers of medical students coming out, that rural practice, for some reason, and it blows my mind because I think it's fabulous, but it isn't something that a lot of people are aspiring to. So obviously, there's lots of ongoing national input into how we can increase more trainees living and studying and working rurally. But really with succession planning, you've got to think at least 5 years ahead. If you don't have someone that you can then kind of grandfather into the community and support while they're still learning, that super senior GPO that's got years worth of experience, that's already got roots in another community, is a unicorn, and the likelihood of getting that person into your community is tiny. So I think we need to be thinking longer game, and it's really challenging for a lot of practices around the state because we do have an aging workforce. And as Nisha said, we need more flexible working environments because the generation of newer doctors that are coming through these days are expecting flexible work environments. So we really need to be thinking 5 years ahead to be able to minimise that. And I'm sorry that doesn't help you with your current recruitment in Bairnsdale at the moment. And it sounds like with the number of birds that you're getting, it would be a really attractive place to have GPO trainees coming in and working with you. So if you're interested, please, I know that Peter will be sending out a little feedback thing at the end of the session. We're doing a survey at the moment to try to kind of gauge what each of the services in Victoria, how they're working, pros, cons, are people having difficulties with recruitment, so that we can then form some policy and take this to the Victorian government. to try to suggest new ways that we can do things to help solve these sorts of issues. And I apologise, it won't solve your issue right now, but please, we'd love for you to fill out that survey so that we can get a bit more information about your particular circumstances in Bairnsdale.
Thank you, Louise. Anonymous attendee has struck once again with another fabulous question. Thank you, anonymous attendee. They have asked, why are rural maternity services actually closing? Who'd like to take that one?
I'm happy to go again if you're happy to listen to me again.
Always, John.
Look, it is because of workforce is probably the primary reason, but also, you know, they have been closed in areas where we've had adequate workforce as well, and it comes back to this this presumption of lack of safety. So, and we've called out many governments on this when they've closed units because they're having some workforce challenges, that they're still functional, but it's just easier and it costs a lot less to consolidate services centrally. So I think that there is a financial driver to this as well for a lot of health service districts where there's a pattern of centralising services, and this is just another step towards that, because it is so expensive to run an operating theatre and to continue to run a birthing service. I think it's really short-sighted economics though, because when you look at the cost, not only the social and economic and personal costs to the community, but when you look at the cost of retrievals and the cost that's required to deliver these women anywhere, you know, there's still a quantum of money being spent on birthing, and where that is, in terms of their health economics, it doesn't matter. And often there's cost shifting into things like the ambulance service and retrieval services, and then into different districts to larger hospitals as well. So I think there's big economic drivers to downsize rural hospitals, and I think it comes with a lack of appetite to pay premium wages to try and recruit, whether it be nurses or obstetricians as well. So that's my view on the root cause. I think there are a lot of economic drivers, and they hide behind the guise of safety when they're making these calls.
Any other thoughts from the panel on anonymous attendees, the crux of the issue?
I think John has done a good job.
Summed it up, perfect.
Yeah, without workforce, you can't run a service.
We've got some comments coming in, and I'll just read a couple of those out for interest. We've got Sue Harrison's made a comment that for too long, health services have relied on GP practices and the goodwill of GP VMOs to take responsibility for staffing issues. GP proceduralists are not valued as they should be, both financially and with support for ongoing education, etc. Thank you, Sue. And Michael Connellan has also made a comment in the chat. He's said, agree with Nisha re part-time work availability, but part-time GPO means part-time caseload and part-time experience and part-time maintenance of skills, etc. So less attractive to newly minted GPOs. It also means we have to recruit 2 doctors and provide recruitment fees, incentives, rental assistance, etc., etc., etc. A bigger issue for rural practices, which are generally private-run clinics. I'm not sure if any of the panel want to respond to any of those comments. Otherwise, I can move on to the next question. Nope. Well, we've got a question from Jasmine, who I happen to know is a fabulous rural medical student. So thank you, Jasmine, for submitting your question. She has said, what impact do you think the Victorian rural generalist pathway will have on rural maternity services? Do you think it's likely to increase the number of rural maternity services in the long run?
The goal will be to at least maintain what's currently running, at least. And then once we've ensured that the current services that are already operational are sustainable and can continue, then we might see like some of these places in Queensland where there's been services that have been closed for years but are now springing open again. And I think that would be amazing. I would love to see that happen. But I guess the main priority is, as I mentioned before, we've got this aging workforce that are looking to retire in the not too distant future. And we really need to be thinking about just supplementing and then replacing those doctors that will be leaving the workforce shortly, but obviously wanting to continue to build up in future where possible.
Yep, John. Oh, John, you're on mute.
Isn't that the saying of 2020-21? Sorry. Look, I think, rural generalism is definitely going to improve. It's definitely going to improve rural procedural services across the country. Rural generalism was born in Queensland on the back of an unashamed workforce initiative to restaff our procedural hospitals. That's what it was originally. The original intent of rural generalism in Queensland, which was state-based and sponsored and still is. What the three key pillars to rural generalism are recognition, and in Queensland they got legislative recognition of rural generalists as near specialists, so basically were matched on the specialist pay scale within Queensland Health. That recognition is going national with a current application which is underway for AMC accreditation for rural generalism to be recognised as a subspecialty of general practice, which is supported by both colleges. So we've got the recognition piece, and then with that needs to come increased remuneration and incentives. And then the other pillar to sort of rural generalism is better and supported sort of premier training towards that endpoint. So state-sponsored and supported education, partnering with the RTOs and the colleges to deliver a structured pathway that sees people to that endpoint of rural procedural practice. Now, one of my bugbears with the conversation of rural generalism is that because it started off with a procedural focus, it became very trendy to start sort of moving away from that and saying, oh, it's not just the obstetricians, it's not just the anaesthetists. I actually think this pendulum has swung completely the other way to what people now call sort of the cognitive disciplines or the non-procedural disciplines. I think it's a little bit offensive to call obstetrics non-cognitive. And I think all of our disciplines have a really important place in our communities, but I do honestly believe that it's a challenge to rural generalism as a procedural workforce incentive is if the system moves too far away from focusing on procedural generalists, which is how it was born. And I think if we want it to be a driver for rural maternity services, we need to make sure that there's balance, that we're supporting all disciplines and that we don't inadvertently ignore the procedural disciplines because we're focusing on other specialties as well, which I think is a risk.
Well, that's MBS rebates, isn't it? Because I feel like mental health's the main thing that people are being concerned about, and that does take a lot of extra skill set and a lot more time. And the current MBS rebates are, I'm not going to use the words I would normally use given the public forum, but not adequate. So I think that's where we need RDAA to continue, and ACRRM and RACGP to continue lobbying for better MBS rebates for our colleagues that have a special interest in mental health, because God help them, it's not me. So thank you for taking on that caseload for me.
And I will take this opportunity to just point out that for anyone interested in mental health, we will be doing a panel later this year as part of the virtual speaker series. So come along to that one as well, and you can hear more about this fascinating issue. I'm mindful of the time that we're going to have to wrap up soon. And I'm wondering maybe if I might throw it over to each of the panelists in turn to give your sort of final reflections, final thoughts. I'm sorry that we haven't been able to get to all of the questions thus far, but Nisha, did you want to kick us off with maybe some final thoughts?
Sure. I think often what happens with rural maternity services, like probably is happening on this forum as well, is that there are a whole lot of people who are already invested in rural maternity care at this forum discussing how to do it better. There's a piece of work to get the people who are sort of not as interested in rural maternity services. And I am assuming, and this is a big assumption, that these are my city colleagues who are obstetricians based in the big centers in the cities, for whom rural maternity services is just that thing that happens out there. But actually, it's getting us involved in that conversation and making sure that we provide the support that will make sure that rural maternity services keep going is a really important piece of that full jigsaw puzzle. I think it's that one little missing piece. And if we could get that in place, then we will have a much better cohesive approach to keeping rural maternity services open. Generally, people in the city have much louder voices for one, so we might as well shout about things that can help our rural colleagues.
Thank you, Nisha. Louise, do you want to give us your sort of final reflections, final thoughts?
Such an important topic. I don't know if I can encompass it in only a sentence or two. I guess from a trainee perspective, making sure that we've got appropriate sustainable trainee options moving forward as people progress through their careers is super important for me, and something that I know that that's where I come from on our little RDAV maternity working group perspective. I'm just going to plug it again. We do have meetings monthly at the moment, and if anybody in the audience is keen to participate, we would love to have you, particularly if you're in the southwest, the very, very northwest, or the northeast, because these are areas that the current little working group hasn't really been able to fill. Peter, I'm sure in the post-attendee email will put some information about our next meeting, and we would love for you to come along. As I said before, that survey that we've been promoting via social media about current obstetric services in Victoria is vital for us to kind of get the information from you, the clinicians on the ground, or the aspiring clinicians who are coming through, to know what your major concerns and your issues are, so that we can then develop some policy and then take it to the state government to try to make life better and make rural maternity services more sustainable moving forward.
That's a great tagline, Louise. Make life better, make rural maternity services more sustainable. John, do you think you can top that in your reflections?
Not going to be topping it, but I want to say a massive thank you to you, Sky, and to the RDAV organising committee for highlighting this as such an important issue. I would like to say that we're winning the war with rural maternity. I think we're seeing progress. We're seeing maternity units reopen. I think we've won the safety argument. Now we just need to back it up with getting workforce out there and supporting all of you that are working so hard on the ground to deliver these services every day. And we have every intention to do that. And I think to get there, we need to all be right behind rural generalism in every forum that we can be, so that we can push this further and we can start to target some of these workforce issues and engagement issues that are blocking, so that, you know, as Louise says, we can make the world a better place going forward.
Thank you all. Everyone, I'm sure, will join me in a virtual round of applause for Nisha, Louise, and John. And I'd like to thank everybody who attended for coming. There will be an evaluation email sent out to you. Sorry about that. But we'd really love it if you did fill it out, because running these virtual sessions is obviously something new that we're doing. For those of you who have been members for RDAV for some time, you'll be aware that this is new for us, and we would really like to make sure that these sessions are interesting and useful, and contributing positively to the conversation. And I suppose, as the tagline has become, solving the problems of the world. So if you could fill that out, that would be fabulous. To plug Louise's working group again, if you want to join the working group, you just have to be a member. And then you're more than welcome to come along to their meetings. There's also the survey, the Rural Maternity Services Survey, which is out. We'll include that in the evaluation email so that you can fill that survey out. And that's going to be really important to our advocacy work going forward. And there'll be information on our website about the upcoming events. There's going to be one of these events every month. And on different topics, so stay tuned. We'll be putting more information out about that as we go. So in conclusion, thank you so much for joining us, and we hope to see you at the next one.